All right, well, I think that we can get started then. All right. Good evening, everyone. For those of you that don't know me, I'm Greg Benedetto. I've been with Selling Biosciences for about 8 years now. I've had many roles over that time. Currently, I'm the Director of Clinical Education. And what we like to do is, we'd like to hold these webinars from time to time and sort of get some information out there. But at the same time, we like to create a forum for everyone to discuss, ask questions, and talk about just general information that has to deal in the world of biologics. And how that works is, in terms of whether we're talking about stem cells and bone marrow and talking about PRP, or maybe anything else out there that you've heard of, whether it be amnio or Wharton's jelly or any other type of stem cell-like product. We have many experienced physicians that have dealt with it. We've seen it all over the place. What I'd like to encourage people to do on this webinar series is to ask questions. Dr. Gaunder is here because we have been working with him for about 4 or 5 years now. Me personally, he's been around before me, but I've got the pleasure of working with him for about 4 or 5 years when he was at Wright-Patterson Air Force Base. Currently, he's an orthopedic attending at Piedmont Health System in Georgia, works with the UGA football team. I think that overall, he's probably one of the best physicians I've ever gotten to work with. And even more so than being a fantastic physician, he's also a very good businessman. And, sometimes those two go hand in hand, and sometimes, one doesn't do well with the other. But it's been interesting working with Dr. Gaunder because I feel like everything he touches turns to gold. I kid you not. So don't hesitate to ask him any type of questions, starting a business, starting the biologics business. He is a physician in our network that we value. And if there's ever a time where, someone wants to reach out or somebody wants to speak with Dr. Gaunder about anything in particular, we can arrange that. I'm sorry, I'm just being told that my camera is frozen, so I'm just trying to get that fixed. All right, I think that's better. I can see me. So please ask questions. You can raise your hand using the hand raising icon. Gracie will identify your question. We'll stop in the middle of the talk. We want this to be sort of an organic affair where we are asking questions that are coming up. You have concerns, whether it's about, maybe it's aspiration techniques, maybe it's patient identification or post-treatment protocols. Anything that's on your mind that you're curious about, this is the forum to do it. So without further ado, I want to introduce Dr. Christopher Gaunder. Dr. Gaunder, thank you so much for being with us tonight and taking time out of your schedule. Please, the floor is yours.
I appreciate that, Greg. Thank you for the invitation. Appreciate Selling hosting this for us. It's an exciting topic. It's been around, but everyone doesn't completely understand, either what it is or how to best utilize it or where to utilize it for your patients or who to choose for it, who not to choose for it, what are the indications. And so this is really, kind of my thoughts, and feel free to disagree with me. Feel free to say that doesn't make any sense. Feel free to take whatever you want and adopt it as your own and call it your own. This is just more, 10 years in this space and anecdotal experience through different variations of my practice. A little bit about myself. I started out in my residency at Brooke Army Medical Center in San Antonio, Texas, where I was active duty in the United States Air Force. It's kind of where I initially got started in the biologic space. Took that to Wright-Pat, where we had a large population of active duty Air Force men and women who obviously had a lot of different pathologies. Well, my primary role now, just for full disclosure, is I'm an arthroplasty guy in Athens, Georgia, and so I do still treat some of the sports injuries but we had a plethora of them during my time in the military. If any of my military colleagues are on here, hopefully Greg got them to sign an NDA prior to this, just to make sure, everything's kept on the up and up. But no, I valued my 9 years, 21 days. A lot of pathology was seen. One of the most interesting things is we've known that a lot of these biologic injections work very well with soft tissue injuries, and we'll talk a little bit about that tonight. Why? And then one of the interesting things, we had a huge plethora of military individuals who probably had, relatively in-stage arthritic changes in hip, knee, shoulder. And so, and in light of not trying to give a 30-year-old a total joint, um, we utilized techniques in and around these regenerative therapies just to buy as much time for these individuals as we could, and had a lot of different results, and would love to talk about those tonight as we go through it. I think the majority of this evening is to discuss all regenerative therapies and compare and contrast to what we're all using probably today in most of our practices. Like Greg said, feel free to stop me, stop us, ask questions. We're going to talk some science, but there's going to be a lot of talk just about techniques and protocols and things like that as well. And so if you don't ask the question, we can't answer it, but otherwise feel free to fire away. Um, Anybody got anything with that? Otherwise, we'll get started. All right. Greg, if you want to go to our first slide, we'll get going.
Absolutely.
All right. So if you've been around selling at any point in your time, you've probably seen this slide at some point, but this is just kind of to go over the regenerative types of therapies that are out there. And a lot of us fell kind of backwards into this. We didn't necessarily, some of us did, you know, lots and lots of research before we used our first biologic, and some of us kind of fell into it because it was the buzzword or hot topic or new adjective with whatever repair we were doing the day in the OR. And so this kind of outlines a little bit of the regenerative therapies that you probably are most commonly familiar with. It also highlights the makeup of those therapies. And so you've got bone marrow and PRP, adipose, amniotic, placental tissues all at the top. We've got other names along the side there, kind of highlighting their pluses and minuses in terms of what cells and growth factors and whatnot are predominantly in each one of those regenerative therapies. At the end of the day, we can argue the points of which one's better for which and leukocyte poor and rich, and we can talk about all that if that is the topic of interest. I think in general, we could talk just comparing this to what we normally have to offer. And some of this is just purely my thought process in using biologics, how I like to use them, where I use them. I think, there's still a place for our traditional um, visco supplementation and steroid injections uh, in the practice of medicine. I don't think that those go out the window because we have all these fancy biologic dressing or therapies. However, I think it just requires us to be a little bit more cognitive who we're using what on and why we're doing what we're doing. For me, steroids are, if I have a patient that I'm wanting to keep for life and they come in and tell me, I'm going to Europe tomorrow for once in a lifetime trip, with my bride, and we've been planning this for 10 years, and my knee has exploded, you know, I'm not going to then break out the nuances of discussing the benefits of bone marrow aspirate or adipose with them. I'm going to shoot them with a steroid. I'm going to say, enjoy your trip next week, come back, and we'll talk about the rest. And so, I think, like anything in medicine, it's got to be thought provoking and it's got to fit the patient, their desires and their what their goals are. If you've got a patient who is sitting in your office and from an OA standpoint, and they just are really beside themselves with this diagnosis, and they feel like it's the end all be all, and they really want to unpack what's out there and find other options and avenues at which they can kind of continue to live their quality of life, um, with less discomfort and pain. I think that's the patient you can start unpacking some of this stuff for. And it's hard because each patient is different. It also requires, you know, time, energy, and effort, which is, one of those things that isn't always reimbursable in standard CPT codes in our practices. So, but I think, I don't think anything that we're talking about here, as a joints guy, is putting me out of business. Otherwise, I would say the opposite. I think, what we're talking about here is winning patients over because they know about this stuff. The industry sponsors are direct marketing to these patients, and they're talking about it to them if you're not, as their provider. So I think having the conversation and letting them know that you're educated on these things and that you're interested in their well-being, their whole journey, whether it's from their physical therapy to their non-operative managements to their procedures involving regenerative therapies or not, and their options there, and then ultimately their surgery. So I think it ends up actually winning patients over. I don't think you're chasing anyone off, or you may delay surgery for a period of time. Ultimately, I see it as they're either mechanical or biologic issues, with whatever we're addressing, and we'll talk about this in more in depth with other soft tissue pathologies later. But from an OA standpoint, if there's a severely mechanical derangement of that knee, there's only so much you can do from biology standpoint, whether it's regenerative or HA or whatever therapy, until that mechanical derangement is corrected. But in the patients who are having truly degenerative changes, catching this early, if you can change the cultural milieu, so to speak, of that joint from a very early point, really decrease the metalloproteases and stuff that joint is seeing on a day-to-day basis, then there maybe is some preservation of that joint space that can carry that patient on, and they can have a much more fulfilling outcome from their non-operative management. Any questions with any of that? All
I'm
right.
I'm gonna I'm gonna hammer home 2 points, but this that you said that I thought were fantastic is one, because I get this question a lot, is people are always asking me, okay, what should I do for this tendinopathy? What should I do for tennis elbow, or what should I do for shoulder? And Dr. Gaunder nailed it. Said everybody's different. When you're gonna treat the 52-year-old male that might be obese and has knee problems versus the 41-year-old female that just wants to keep running every day, there's different options, and I think you nailed that. And I think what's also important that you said too is that there are all these different options out there, and there are more and more clinics popping up that are injecting things. And I don't want to say irresponsibly, but they're doing it without the knowledge that orthos have. And so I think it's actually creating a little bit of a dangerous scenario of people going out there and getting these treatments that, we're just, we don't really know what they are. They don't know what they are, and the clinic doesn't know what they are. So I think that's a great point, that everybody's going to be different, and then we're going to treat everybody differently. So sorry, I didn't mean to steal your thunder, but I just thought those
No,
were
no, no.
great
That's,
points.
I just read a position paper from the AAOS, guys on stem cells and stuff like that. And I wasn't a huge fan with how they worded it, because it was basically that. There's a lot of stuff out there. I mean, you think about the PRP systems, there's, over 100 different systems, and what they're putting back into each joint is drastically different. Obviously, I've kind of fell in love and started working with selling because of, I believe that their yield is substantially, um, on the up and up in terms of what we're putting back, and definitely bone marrow and PRP as well. And so, but unless you're diving into the research and nuances of each system individually and how they're they're engineered, it's really hard to know exactly. I mean, I can go anywhere from, a sophisticated system to basically a hand shaken PRP system I can, buy off Amazon. I mean, it's really kind of crazy. And then we want to label a study comparing those two when obviously we know it's not the same, substrate we're putting back toward to the patient. Um, and then when you do that in non-medical settings, you get these, cases of E. coli or whatever popping up in, 16 of the 42 joints that were administered that. And it sparks an FDA concern. And so, yes, there's a lot that goes on with this that's just not regulated, and unfortunately has given a lot of it a bad name and tainted it. And then the academies basically force, the people who are going to benefit the most, quote unquote, from this is the industry. And so they make them responsible for the studies. However, once Stelling puts out that amazing paper that says they really think they are helping patients here, then it's tainted literature and it's biased and all that other stuff. And so for us as physicians, it really, leaves the onus to bear that cross and kind of create good, substantiated studies around that. But we know that doesn't, it's very time and labor intensive, it's personnel intensive, and it's hard to do as well. So a lot of the stuff that we're seeing day to day doesn't get, to the journals and white papers as frequently or as fast as we wish it would. And so I think this forum is great to discuss what we're seeing, what we're not seeing, and take it for what it is.
Absolutely. And I want to include our pain management people in there as well. They're also doing great work out there.
Yeah.
I didn't want to just insinuate that only orthos are doing this. But and the other thing that I see is that patients are asking for these procedures more. Patients are coming in asking about stem cells, asking about PRP. Is it beneficial? And even if it's not part of everyone's practice, it's important, I think, that we all know what's out there, what people are offering. So, all
Absolutely.
right. So moving forward, Dr. Gaunder, let's discuss what we're targeting
Yes.
in PRP and what we're targeting with BMA.
Yep. So PRP is, platelet-rich plasma, and we're really trying to tap into the, platelets and the growth factors, and we're using this adhesion activation aggregation kind of model that's outlined here in this slide. And the goal is that, you know, particularly we're talking, more soft tissue injuries here than we are synovial fluid, but there's an intricate cell signaling process that's going on here, and our goal um, is to create more native tissue and less scar. We know scar uh, functions, uh, but it's not the equivalent of truly functional tissue in the sense as a pre-injured tissue. And so, utilizing all these, you'll, hear us say and talk about, we're basically taking, our eighth grade biology understanding and trying to manipulate that to generate a, whether it is a more robust, better, faster response in the healing cascade than our bodies actually do. And then we're using it too in some areas that we know are biologically devoid and struggle with healing for whatever reason. And we'll talk a little bit about that in terms of where we're placing this subchondrally. And then I think the biggest testimony to that is the literature around osteonecrosis, which is phenomenal. There's demonstrated in multiple peer-reviewed papers that, development of BMA around osteonecrosis can be extremely beneficial in treating that in the early stages. So just to give you an idea, this is kind of what we're targeting. You can go to the next slide, Greg. Again, this is the normal healing cascade, and this kind of overlies our regenerative properties into it and kind of outlines a little bit of where we're trying to take this, how we're trying to speed up that healing process. And by doing that, you know, preventing more normal tissue formation and less scar. Go to the next slide there. This is a very complicated slide, but I think it kind of illustrates a very poignant um, example that we're trying to make here is that what we're trying to do is recreate this amazing network of cell signaling that ultimately leads to tissue regeneration. An incredibly complex network, and so if we can, steal an example from how our body already does it, and then reinstitute that in a way that benefits our patients, it's ultimately what we're trying to do. Um, don't ask me to walk you through the cell physiology of this. That's why I made Greg join me on this call, just in case we had a cell bio major here that wanted to, correct this slide. But you get the process here. It's extremely intricate. It's extremely interwoven. And the other thing it does is it touches multiple things. And so if we can utilize the way the body normally works to help activate that, I think we can benefit our patients moving forward. Next slide.
Absolutely. Yeah. And again, for those that came in a little late, you are encouraged to ask questions during the talk. Please just there's a hand raising icon and we'll get your mic unmuted. But please, peer-to-peer interaction, please utilize Dr. Gaunder's knowledge. That's how we make the best strides. Go ahead, Dr. Gaunder.
And so again, when we're looking at BMA, bone marrow aspirate, what are we targeting? What are we going for? I think you got two big camps with the MSCs and HSCs, and you can kind of see where they're at in the tissue and what they do. We also really try to go after the other progenitor cells when we're utilizing these substrates and regenerative properties to really activate tissue healing. But this is kind of what we're trying to capture with our bone marrow aspirate. Next slide. Similar to the PRP, we've got places that this tissue product ultimately ends up ending their signaling pathway, and you can kind of see this outline there. Again, when we talk about what is BMA doing on a cellular level, it's very nuanced, and I don't think there's any formal, true. We can hypothetically talk about it the way we know normal anatomy works, but knowing why we see the results we do with BMA, whether it's synovial fluid, an avascular hip, tendinopathy, all of these different areas that we're, recommending use or have seen it used in a clinical practice. But this is why we think it's doing what it's doing. I'll be the first to say, again, the new guys, I'm a joints guy. I don't think I'm putting myself out of business by utilizing these, particularly BMA or PRP. But I do think it's a powerful, powerful anti-inflammatory agent, and the way that inducts signaling to truly immunomodulate inflammation is pretty powerful, and been able to thankfully see that through my own practice. So, next slide.
Dr. Gaunder, and this is a tough question, so I don't
Sure.
want to, I don't mean to put you on the spot, just because there's a lot of factors that decide it. But as you're practicing more, I know nobody knows more about the risks of a total joint replacement more than you, and everything with patients. And that, I mean, there's certain patients that you would identify that maybe you would push towards an injection before trying to do the TKA, or is there something that you're looking for? And again, I mean, I'm just asking. I don't know if there really is, because I don't practice medicine, but
Sure, sure.
I think I
Yeah.
get that question a lot. I mean, people want to know how to identify patients and maybe, sort of what they can do for them and what's actually going to help them without
Yeah.
saying, hey, doc, you just made me spend all this money on an injection and it didn't work.
Yeah. Yeah, I mean, it's tough because I think it does go into the patients you see. I mean, you're going to see patients in, 15 degrees of varus and completely blasted, plateaus from their femur kind of eroding into it. Those are probably not the patients I'm going to go straight to developing, you know, a big drawn out spiel on the benefits of PRP or BMA and preserving the life of their joint. It just doesn't, probably make a lot of sense for that patient. I think at that point it's, do you have to use injection therapy at all? I think the answer is probably no, unless you're, as most of us are, tied to insurance, and it's a qualifying factor for approving the surgery. And in that case, I think a simple steroid is probably the best to say yes, there was efficacy, but it didn't last. However, I think as you go to this next slide, it's kind of interesting. It sums it up. You've got, and I'm going to use this to kind of answer your question. But we've got the substrate, the BMA, PRP, whatever we're choosing. We're adding natural growth factors, but there's got to be a matrix for which that kind of adheres to. And this is just simple, healing pathophysiology that nobody would refute, right? And so similarly, when I think of a patient that I'm trying to evaluate to say, hey, is this person going to be beneficial um, from a intra-articular injection for BMA or PRP? This is really kind of what, in not so many words, goes through my mind. It's like, okay, I've got an option that I can give them in BMA or PRP. Are they a good candidate for it in terms of overall health and things like that? There has to be a certain activity level that I think those patients are wanting to get back to. If you're trying to get out of a wheelchair and get to a walker, maybe this isn't the patient that I'm talking about PRP for standard arthritis in, but there's got to be some sort of um, and then as you get x-rays on the patient, you're identifying, you know, kind of their anatomy, where they fall. That patient that I was alluding to with horrible varus and, you know, just the femur eroding into the tibia is probably not the best patient. But if I see a patient that's relatively neutral mechanical alignment, but is having early wear, whether it's from slight amount of varus or prior trauma, or even an ACL reconstruction 15 years earlier in life that may have changed the overall alignment, maybe there is some joint space there, although we have seen it in, relatively arthritic joints. But the overall alignment's there, then that matrix, that backbone of which that PRP can facilitate its effects is there in place. And so the other thing is you're looking at painful total joints or painful knees in particular. MRIs sometimes are not beneficial, but the patients I do see a real benefit in this are patients who get MRIs and there's a focal almost bone bruise or osteonecrotic spot in that medial tibia where there's still joint space left. Maybe that's a patient that you can stimulate healing, whether it's intra-articularly or even a subchondral injection into that particular defect, similar to the way that we see benefit in osteonecrosis and devoid uh, um, blood flow areas. So I know that's a long-winded question or answer to your question, but it's patient derived. There has to be, some sort of mechanical environment that says, hey, this patient's got a chance to kind of save this space, right? If Yosemite Sam walks in and that much varus, there's not a lot you can do, unless you've dealing with it with whether it's an arthroplasty or some sort of osteotomy or something to change the mechanical alignment, and then maybe PRP can work in that patient. So any questions before we get into kind of overall uses, patients, protocol, anything like that around the science of what we're doing and things like that?
Gracie, anybody have their hand up? I can't see everyone's icon.
No, not at the moment.
Okay.
All right.
All right. Well, we'll press forward.
Well, we'll keep moving on in terms of kind of treatment and what we're doing. Really, this is a very general overview and kind of we're looking at hip, knee, uh, upper extremity, and foot and ankle, where our practice is using it primarily. I will say in general, a lot of our protocols, when they involve a joint, are, are identifying the correct patient, administering the treatment, reevaluating that patient critically, and then plus or minus instituting a second uh, injection. Um, Usually, our my kind of protocol there is 50% better, 4 to 6 weeks would indicate a second injection. Zero benefit at 4 to 6 weeks. I really can't encourage the patient to truly try a second injection. And then we have patients that, swear they're significantly better and want to continue to ride, um, you know, the benefits they're receiving from that treatment. So that's kind of for synovial fluid, that's kind of where we're at. For most of the soft tissue that's identified, it's usually identify the pathology, um, administer the treatment into that soft tissue area, and then there's a period of rest for 2 to 3 weeks, and then there's an administration of some sort of physical therapy, return to function activity in that individual, usually guided by our you know athletic trainers and sports physical therapists. So you know, that's kind of the general overview. Some of these are nuanced, um, but in general, that's where we're going with this. And so, looking at the knee arthritis, we're administering both intraarticular and subchondral. You know, I use these two examples. I don't know where this picture came from. Obviously, the one on the right there, that complete loss of joint space, you know, again, if that person's 75 and they just are in pain every day and can't sleep, maybe that is a patient that's going straight to an arthroplasty. But I've seen that exact x-ray in a 35-year-old airman. And so I just can't come to terms with a total knee replacement. And we've had to do it. But those are the individuals that I really want to tackle, um, and try to give them, even if I can give them 5 years of good quality of life, playing with their kids and all that stuff. Even though I feel, you know, an arthroplasty, when done well, can give them some of that. There's still nothing like their native knee joint. As long as their quality of life and function is still, to the level at which they need it to be, you can always go to a knee joint. You can't always go back from it, right? And so, keeping them with their God-given anatomy is always, I think, beneficial. However, so that's hopefully an example, Greg, of maybe a really bad um, uh, kind of canvas that I would consider using PRP or BMA in. Now, conveniently, this picture, the other one where you see a normal joint space, and I would agree is a normal joint space, but envision with me here, if you ever look at x-rays, that medial compartment's a little bit sclerotic, right? And they're seeing a little bit more wear. Maybe this isn't a weight-bearing film, and you get a long leg alignment film, and you see some compression in that medial compartment, and get an MRI, and the meniscus is intact. But when you see that they got a little bit of increased pressure there, in weight-bearing films, and now you get a MRI that shows, some focal edema kind of right below that medial compartment. And that's exactly where they're having pain. And you're like, man, that joint space looks too good, really, right now for an arthroplasty. Mechanically, they're well aligned. This is definitely someone who says, Doc, do I have to get a knee replacement right now? And the answer is no. We've got a plethora of options for you, um, you know, that we can administer to try to preserve the, as I used earlier, cultural milieu of that joint, and try to make it happy, try to decrease the inflammatory cascade that's going on, decrease the metalloproteases, and um, kind of help that patient have more improvement early on. Was there a question there, Greg? I think I saw.
Yeah, remind everybody, how long do you see the patient after their initial injection? Is it 6 weeks?
Yeah, so I'm, administer injection, and then 4 to 6 weeks, there's a follow up, right? And at that appointment, it's, hey, have you been? What's going on? I expect functional activities to be, relatively back to normal. I don't necessarily, for arthritis anyway, I'm not necessarily using, um, you know, return to sport or anything like that as part of that 4 to 6 week involvement. And I'm really using the patient's experience. If they're saying, yeah, I honestly feel like my knee's less inflamed and I'm, 50+% better, I'm usually recommending a second intervention at that time. Try to get to that second injection within that 6 to 12 week time frame. And the goal there is that hopefully there's not a third intervention needed 6 months to a year is usually what we're seeing.
I think that's great, because it's probably one of the top 5 questions I get. Everyone's always asking me, okay, how many injections do they need? And I think there's a lot of uncertainty out there. Some people, and some people who have, we work with, believe that it should be 3. And I'm not saying, I don't think they're wrong at all.
No, not at all. There's some
Yeah,
literature out by Brian Cole that talks about the magic 3 injections. And, obviously, again, looking at what you're putting in and, and where you're putting it, I think matters. Taking a patient to the OR for a subchondral injection 3 different times, probably not the right answer. But I think if you're using an intra-articular space and, the patient has the means to do 3 injections, that's the beauty of this. You're
yeah,
definitely not harming the joint by doing that third injection. It's really predicated on what their goals and aspirations are. It's hard for me to justify it. 6 weeks, I do one, you know, 8 weeks, I do a second, and then I see them back, 6 weeks after that, and they're like, I'm no better. It's hard for
yeah.
me to then justify that third one. But I feel like, man, I didn't believe you, doc. Each injection's gotten more and more, effective. I mean, when we're thinking about what we're administering, and I use it, feel free to, if this makes sense to you, take it and run with it. If it doesn't, trash it. But, patients ask me the difference. And, I say, when we use our traditional treatments, steroids, hyaluronic acid, it's like coming into the joint with an atomic bomb. We're just squashing everything, right? And over time, it builds back up. Well, the opposite is with, our regenerative therapies. We're coming in and we're actually stimulating them to a certain extent with the cell communication. But the idea is that that stimulation is tampered with time, and that as you expose that joint to additional activities, it's not going to respond in the same deleterious and extremely inflammatory way that it's been responding in the past. And so multiple injections, when efficacious, are beneficial, where I would not recommend using a steroid or hyaluronic acid in the same manner.
Right, right. And I think that's an important concept and question to ask yourself for all of our physicians out there that are just starting off in this, because I hate to say it like this, but we have to sell it to the patients, right? I mean, we have to keep the lights
Yeah.
on. Everybody has to work and everybody has to make money. So I think that sometimes it's better for the patient when we're selling them a treatment plan. But like you said, okay, I've already done 2 and I don't feel better. So yeah, it's tough out there for the physicians. I think you guys have to toe the line between, okay, we want to help you, but we don't want to overcharge you, but we all have to keep the lights on.
Yeah.
It's tough, and I think it's hard for you guys, and we acknowledge that, and that's why we try to get as much data. And again, we offer all of this peer-to-peer interaction, so you can feel like you're going into those consultations with confidence, and you don't think that you're doing wrong by your patient. So I
Yeah.
know that I get that question a lot about that. So thank you for touching on that.
What did that answer the question in the chat room? I saw it come up.
Yeah, there's actually another question in the chat
Oh,
asking when to use BMA versus PRP in the early stages of arthritis.
oh,
Yeah,
great question.
that's a great question. Honestly, it's really kind of dealer's choice. I mean, I think if I had, well, I mean, so my time in the military really had unlimited resources. In terms of when we indicated patients for this, there was no charge to the patient. They didn't pay any more for their PRP than they did, their aspirin or their steroid. It was all kind of part of their care. And so really got to kind of, I won't say, let's say practice medicine in the sense of trying to figure out which one would be the candidate for BMA versus PRP. If you're using BMA, there's a procedure associated with that, and we can talk as much as you guys want about, how we harvested what we did. I did not harvest in an operating room. I did all my harvest in clinic. I actually um, started with one of my pain management colleagues, and we did them together. He was anesthesia pain management, and we started using, he would help make the patient comfortable in clinic, and then I would harvest and then re-administer and whatever joint. We went away from that because it just was overkill. We just didn't need it when we were using the PSIS technique. We can talk more about that if you guys want, but I think BMA is going to be a more powerful anti-inflammatory agent, bar none. However, in the military, it was very easy to go to BMA. And a lot of people had come to us who had failed multiple other injections. And so it's like, oh yeah, you don't think these work? Let's try BMA. And almost unanimously, with a shocking number of patients saying, wow, that was different in a beneficial way. However, outside the military, there's definitely financial implications to that. And so I think, unfortunately for us, most patients fall, hey, if I'm going to try something, let me try PRP first, in this early arthritic phase, just to kind of like toe in the water to this regenerative medicine stuff. And let me see if it works. They're either skeptics or not. But some people ask for it. And I really, if I had ample resources and I would probably steer to BMA as that early arthritic, protecting the joint space, decreasing the metalloproteases, and really tamping down cell signaling. But I think PRP does do a good job in that. Probably not quite to the potent level that BMA does. If that answers the question.
That's great. And by the way, just when we say BMA, and I'm guilty of it too, what we really mean is that we're doing BMC, which is bone marrow
Sure.
concentrate. Yeah, and Dr. Gaunder, I do this all the time, and
Yeah.
somebody just reminded me that we're doing bone marrow concentrate, right? We're harvesting, we're collecting about 60 cc's, and we're spinning that down, and we're isolating the stem cells. It's very different from just harvesting some bone marrow and mixing it with bone graft and things like that.
Yeah.
So
Sorry.
I get lazy on the language. So thank you for reminding me on that. But everything I think Dr. Gaunder said there is great. For some of my distributors out there that are listening, he's right. Bone marrow is like 10 times more potent than PRP. It's a very powerful mitigator. And so it's a little bit more invasive. Not everybody's always signing up for it. The PRP is definitely easier to do. But in terms of its potency, Dr. Gaunder hit it right in the head.
Yeah. Just to keep things moving, I want to respect everyone's time. We just want to touch on some of the other areas, but please stop me and ask questions. This is what it's about. In terms of the hip, obviously osteoarthritis, similar kind of treatment algorithm to our knee arthritis patients in terms of that. Avascular necrosis, I would put in that kind of subset of like, a severe tibial lesion with a lot of bone marrow edema. Avascular necrosis is this really unique process where the femoral head loses blood supply, and we see, deleterious changes in the cartilage and collapse of the femoral head. There's significant evidence to say if we can catch this early, a lot of your patients will present to you, with relatively normal x-rays, that young patient population. Um, this doesn't make sense. They don't have enough hip arthritis to really warrant, you know, a hip replacement, but it's definitely hip pain that you're seeing the patient for. You get an MRI and you see that, avascular necrosis or osteonecrosis of the femoral head diagnosis. And these are patients who truly benefit. Traditionally we've done everything under the sun, core decompressions, and there's significant evidence to suggest backfilling this with a BMC, PRP, whatever you can get your hands on is going to do better for that patient than your core decompression alone. And so, I think for the surgeons on the call, if anyone has experience with this as well, I'd love to share techniques. I'm always learning. But essentially, it's a large jam sheety in the same trajectory that you'd be putting femoral neck screws in, and you're backfilling with as much good biology as you can jam in there, and then moving on from there. Gluteal tendinitis, tendinosis, partial tendon tears. That's something we've had a ton of exposure to. Again, similar patients, don't have enough hip arthritis. What's going on with their hip? They've got this, complete gluteal tears. I think warrant direct repair. You can make an argument for adjunctive BMC or PRP and in association with that repair. I'm not going to get into the logistics of that, but in partial tendon tears, we've had excellent success with ultrasound guided um, administration of PRP, in particular, into that tendon repair, period of rest, and then a targeted return to activity guided by our athletic trainer or physical therapist. Patients have done extremely well with that. And I use 50%, kind of the same literature that's in the rotator cuff literature. If you're greater than 50% tearing, that's kind of the line that I'm using on advanced imaging to make that determination if they're a candidate for PRP or BMA into that area. Shoulder, upper extremity, the epicondylitis that's well documented that, if you're using, this is one where steroids really have limited use. I feel like, the lateral epicondylitis, I don't know how many people have seen it where they've come into their office with 14 injections, of steroids into their elbow, and they're like, it still hurts, it still hurts. And, it's just a big ball of scar there because it's completely denuded of any biology. So this is one where I really feel like BMC and PRP really shined, and we've seen that. We mentioned the rotator cuff tendinosis and partial tears there. I know we've got some guys in the selling network who utilize that to a much greater volume than I do. But in a non-operative setting, I'm usually using the MRI to guide my treatment. 50% or under tear, I think, are great candidates for some of this treatment. And again, those can be administered directly into that tear via ultrasound. Um, and although ultrasound in itself is its own training, it's extremely beneficial in administering these modalities in a clinical environment. And so, whether it's yourself or an advanced practitioner who you've invested in, who's going to get that training, Greg, give you our information. We'd love to have you down anytime to see how we're doing it. If you want to see one or two of these done, obviously get you on the books to come to Athens. It's not a bad place to hang out. We can show you how we're doing it. But this is extremely beneficial for your practice, for your patients across the board. And then shoulder arthritis, again, kind of falling back into the same kind of synovial joint treatment algorithms. Those are ones that, these are patients who are candidates for total shoulders, and we're administering this as an option for that. And again, it's kind of 4 to 6 week follow up. assess their benefit and administer a second with the goal of getting them into some sort of physical therapy and strengthening after the second and hopefully preventing, a replacement, or, keeping it off for a while longer, depending on what those patients' goals are.
Yeah, and thank you for mentioning that. I mean, we can set up those kinds of training days. We can bring in different physicians for all different types of ailments. We're really looking at what Dr. Gaunder does there at UGA as like a center of excellence for us, because they really are. They're doing a high volume. They're seeing a lot of different patients. They're dealing with all kinds of different deformities. Like I said, it's the network that we've created that I think is the most powerful. We know that there's biologics out there, but to be able to have these peer-to-peer interactions, that's where I really think we make some leaps and bounds in our research for this.
Yeah, nobody wants to be the first. You know, just it's never popular, and some people, I guess would get off on it, but in general, you want to know that this is being done. It's being done effectively. It's being done in a way that it's benefiting patients, and then you want to have a clear pathway of how to do that in your own practices. I don't think anything we're saying or talking about here, uh, you know, I invented, or we invented where we're doing it. It's all been built upon someone else. We stand on the shoulders of giants, and so we're able to take and build and grow. This regenerative therapy treatment we offer. Patients, athletes, and everybody and above through the people who have done it before us. So feel free to come down and check it out. And then just to round this up, because I want to make sure we have plenty of time for questions. Our foot and ankle pathology, again, Achilles tendinosis is probably what we treat the most. We have done some plantar fasciitis treatments. I was recently made aware of that when I was preparing for this. So don't ask me too much about the plantar fascia stuff. But the Achilles stuff is uh, we treat regularly, and these are partial thickness tears that the literature would say, flip a coin whether you're going to fix or not, and the outcomes of those patients. And these are patients that we're able to administer a biology into a relatively minute area of biology, and it responds extremely well, similar to the gluteal tears. And so, again, 50% signal, 50% um, uh, um, tearing. We will try this. These patients more actively get shut down, like an Achilles tear, once this is administered, and then slowly transition to a heel lifts back to a flat foot and then to therapy. But they do exceptionally well.
Excellent, excellent. I think I saw a question pop up. Gracie, can you read that off?
Yes, we had a question from Henry Gust asking, is it accurate to say BMC can be covered by insurance and PRP is always cash?
I think it completely depends on which environment you're using it, right? In an operative setting, a lot of these procedures can be covered by insurance. If you're using BMC in a clinical setting, there's not really if I'm using it clinically for arthritis, um, I have not had a great, I've had zero, to be exact. Insurances cover it. And so that is a cash pay as well. PRP, again, similarly, in a clinical setting, there's some repairs and things like that where augmentation can be attempted to be billed. You don't always know exactly if you're going to pay for it. So, in an ASC, you're getting a prior authorization. Sometimes if you're in a large hospital system like us, it's built into the costs, and so they allow it, which is nice. And I don't necessarily know if that Achilles repair we did that was augmented got reimbursed or not. That's kind of on Piedmont to fight. And so, there are pluses and advantages for both. I will say if you're using it in a clinical setting, you can almost guarantee I have not come across many insurances who will reimburse BMC or PRP for clinical use. There are limited applications in an operating room where it can be reimbursed.
Yeah, I think that's a pretty fair way of putting it. I think we all know that CPT coding is like 50 shades of gray. We just, you never really know what they're going to reimburse, and it gets more and more difficult. There is coding in the OR, but for the clinical setting, you are mainly looking at cash pay.
Yeah.
Any other questions out there? Any procedural questions for Dr. Gaunder while we have him? Anything about starting this up for your own practice or biological augmentation during surgery? I mean, what's on everyone's mind out there? Does anybody have anything they'd like to add or talk about?
We had one additional question from Henry as you guys were finishing up there, asking as it pertains to OR.
Yeah, I think in
Dr.
terms of reimbursement.
Yes.
Yeah, I think anytime you're harvesting bone marrow, I mean, that's obviously a billable code. Now, whether it's being, again, you have to unpack, I think, depending on your institution and the insurance, is that lumped into the procedure? Are they expecting it? Are they not? But I think if you can unpack that, I think my foot and ankle colleagues have had the most experience with that in terms of getting that reimbursed in an OR setting because you can unpack that and bill for the aspirate, bill for all of those things separately, and they're seeing reimbursed. And PRP, though, is the same way. I don't think that's any different. It's just a matter in what you're doing it. You bill for the the drawing of the blood and all of that. So that answers that question.
Anyone else? Oh, hang on, something just popped up. Go ahead, Gracie, if you don't mind.
Okay, we have one from Justin. He said earlier SRs did not indicate that PRP conferred greater advantage versus CSI or other interventions. There have been some more supportive recently. Also, I do see many orthos question the benefits of PRP. What do you think the earlier SRs were missing about the efficacy of PRP?
And SR being, I'm sorry,
Scientific research, or
scientific research.
I'm guessing that's what I thought it was when I heard it.
Systematic review.
A systematic reviews.
Yeah, and so that that's a good point, and I think it comes to the fact that you've got 40. No, you're good, Justin. Don't worry. And I think it comes to the fact you're looking at 40, 50 different systems out there at PRP, and so it's real when you get into systematic kind of review literature. There's no delineation between what you're deriving from and what you're putting back into the host, and so I think that's where kind of the drop in the ball is in terms of peer-reviewed literature around PRP and the benefits of it. I think as we get more and more into what are we actually taking, what growth factors are actually coming with it, and what are we administering back, and how we're administering it back, I think that's where we're seeing better and better research. But that would be my argument to why the early literature was, basically no different, because you're looking at test tubes that you were handshaking and calling it PRP, because you had whole blood you drew and dumped into a test tube and shook it, 12 times. And then you're looking at, a system like Selling that's trying to put a lot of engineering into how they're separating this out and what they're collecting and what we're putting back. So
Yeah, I think you nailed it right in the head. One of the other Selling PhDs is on this call. His name is Ted Sands, and he's taught me a lot over the last year. And it's one of the first things he'll always look at. He's like, okay, well, how did they prepare the PRP? I mean, if I'm not mistaken, I believe the definition of PRP used to be 2x over baseline. It's not hard to get 2x over baseline. So if you're injecting a small amount, you're not going to get a therapeutic dose. And I definitely think that's what some of the problem with some of the earlier papers are. We've done a much better job now at defining the baseline of what a good PRP injection should be.
yeah, and I'd even put some of the stuff in the upper extremity we're doing now for some of our athletes and things like that in terms of being able to, extra concentrate this and then put it into a CMC joint or something like that. I mean, we can really dial this into a really potent 2 cc administration of this, which is just leaps and bounds over automated systems and the original scientific papers that were comparing PRP to other interventions. So yeah, it's definitely different.
Anything else?
Yeah, we actually had one more from Tiagen asking about leukocyte rich versus leukocyte poor. When and where should you use which one?
Great
Yeah,
question,
so
Tiago.
yeah, great question. So, for me, it's anytime you're dealing with synovial fluid, it's poor, it's leukocyte poor. And then really, anytime you're dealing with tendinous pathology, it's the rich. Um, the one, I think that's probably the easiest kind of thing to remember. If you're dealing with tendons, you want to have PRP that's rich. And then that's the easiest way to kind of keep those two separate.
Great answer.
His last part of that question was just about activating PRP.
Oh, so activation of PRP or bone marrow using calcium chloride or thrombin.
Yeah,
I'll field that if you don't mind.
sure.
Honestly, I think that it's a fantastic tool. I think that because you have to think about what you're doing. You're stimulating the cells in that environment. You're basically clotting the blood. And what you have to think about is, cells don't know where they are. Cells are activated and responding to their environment. And so if you induce that clot on the back table before you inject it, those cells are now hyperactive. They are firing off growth factors. I mean, we're basically going back to this right here. That's what I feel that activation of the blood really does. So I think it's an invaluable tool. Unfortunately, sometimes it does add costs. So in the clinical setting, it's not always the best, just because it's hard to make it affordable for everybody and to lower the cost for your patient. We do it more in an OR setting, but I think activating the blood is an invaluable tool, and I would always recommend doing it.
Yeah, that's exactly where we're seeing it. We're not using any activated blood in a clinical setting. It just, from a workflow standpoint and a cost standpoint, just doesn't make sense. But in a clinical or in the OR setting, we're seeing it used much more, particularly with, again, tendon pathologies more so than synovial. But yes, I would agree with Greg 100%.
Anyone else? I don't know if Dr. Ali was able to join us from Quantum. Dr. Layton, if you're out there, I know that Dr. Layton is another sports surgeon that I have the privilege to work with, who has actually really narrowed down particular rotator cuff tears that he would use bone marrow on, and that he's seen good results versus types of tears he doesn't. Dr. Gaunder mentioned about AVN. We had Dr. Chowdhury on a few months ago who spoke about AVN and subchondral necrosis. So, anything that anybody ever has any more specific questions on, we can always put you in front of the physician that can help you, and someone that's out there doing that. We always encourage everyone on this call to utilize our network, because this is what I said, that this peer-to-peer interaction is the only way I think that we really get some good science and good information going. The more and more we publish, great, but I think it's harder and harder to publish these days, in my opinion. So I think exercises like this are invaluable. If there's no more questions, I think we can call tonight. Dr. Gaunder, thank you so much for taking time out of your schedule for this. I know it's a little late for you on the East Coast, but thank you so much. Everyone, thank you for taking time out of your day. This is much appreciated, and please reach out for any questions or resources or assets